So now I'll just run through our agenda for today's institute. Welcome. My name is Preetha Raj. I'm a project coordinator here at the National Indian Health Board. I support all of our maternal and child health projects and program work, and I'll be running through those projects with you later in this presentation. Um, I'll be just giving a brief welcome introduction first to kick off the Institute, and then following my presentation, I'm very excited to have Fatia Richardson and Shaquanna Sebastian from the Mashantucket Pequot Nation to share their project on the Pequot Strong Mom series. They are one of our sub-awardees for our Hear Her project that we're working with the CDC on, and I've had the privilege of working with them for about a year now. So it's been great to see their project kind of from the start and to where they've been able to take it in this last year. And we'll speak more about the Hear Her project later in my presentation as well. Following Fatia and Shaquanna's presentation, we'll be joined by Tess Abrahamson-Richards with Hummingbird Indigenous Family Services, and she will be sharing her presentation on data sovereignty for maternal and child health promotion. As we all know, data sovereignty and access to data is extremely important for tribal health in general, but definitely for advancing maternal and child health work. So very excited to hear from Tess on this. Finally, to close today's event, we'll be hearing from Chelsea Randall with the Great Plains Tribal Leaders Health Board. She's the Maternal and Child Health Director out there, and she'll be speaking on some of the work in maternal and child health advocacy that's being done out in Great Plains as well. There is an option to submit any questions that you may have throughout the presentations. And we are joined by Aubrey Race from the Environmental Health team here at NIHB, who will kind of be helping me monitor the Q&A as well. But please note that all of the speakers have dedicated time after their presentations for questions and answers. So there will be a portion where they'll be able to address your questions and any discussion points then. So just to get us started, I wanted to start with a little bit of a poll. So as we all know, there are a lot of different perspectives, backgrounds, and reasons why we enter into maternal and child health work. And just to get the discussion rolling here, I wanted to ask you all to have the opportunity to share what draws you specifically to this work, whether that be some personal experiences or anything you're willing to share. There's an option to submit a poll. I'll launch the poll now and would love to hear from you about this question. I see a lot of answers rolling in. We'll give this about a little, like a minute more, just to submit your answers. Great. I'll go ahead and end the poll now. Thank you for submitting your answers. As you can see, there are some great responses here for all the reasons that we've joined. A lot of different perspectives here to share as well. And very excited that you all are able to attend today's session. And I hope that you keep these reasons in mind while we go through the different topic areas for advancing maternal and child health. Moving forward, I'll just share a little bit about myself and what draws me to maternal and child health work. So this is a little bit of a personal background for me, but my family is from South India, Tamil Nadu specifically, and we both on my maternal and paternal side have are descendants of the Kurumba people of Tamil Nadu. And these are kind of the main reasons why I am interested and have a strong, reason to be in maternal health. So all the way on the left over here, this is a picture of me as a baby with my grandma. As it is typical in most Indian cultures, I'm the youngest in my family, and so I was raised by my grandparents from 6 months old through about like age 3 out in India. And it's pretty typical that you are, as a youngest, being raised by community. So there are so many pictures and videos of me, with so many people throughout the village. My parents were still in the US, and I was out there in India with my grandparents. And it really created a very strong bond with my grandma, who I'm still very close to this day. My grandma's an amazing person. She is a very strong woman and was the first person in her village as a female to get a college degree. She was a mathematics teacher for her entire career. And throughout her life, she was just such a big advocate for education. She has worked really hard to advance women's rights in education in the small village where she's from and where my family's from, but also in the state of Tamil Nadu in general. And so I've been really grateful to have her as a role model throughout my life, and also as someone who was my first caregiver in life here. And then in this middle picture, this is a photo of my mom and her 2 sisters. So my mom, all the way here on the right, is the middle child of 3 girls. And my aunts and my mother play a really big role in my life as well as maternal figures. My aunts have supported me throughout my education, throughout my life, have given me great guidance and advice. They're wonderful people to speak with if I ever just need, some auntie advice or insights. And my mother is probably my best friend. We're very close. She is an extremely strong woman as well, always curious about the world and life around her, but most importantly, is one of the kindest people that I know and has always tried to emulate, every value and be a good role model to me and my older sister. My mom is also a single mother, and so growing up in that kind of environment, I was really shown firsthand the role that, the mother plays in both nurturing and fostering, but also being a source of great strength. In my culture and in many Indian cultures and other cultures around, it's a very maternalistic culture. So having those role models for me was really important. And finally, this picture is of me and my older sister, just the two of us kids growing up, but my older sister is another mother figure for me. She's taken care of me my whole life, has always been that support system whenever I needed it. And I'm extremely grateful to have her in my life. But I just share this with you all just to show like my background and where I come from, and what drives me in this work is understanding that the role of the mother, the maternal figure, the birthing person is so sacred, both in my culture and as I've come to learn in many tribal and native cultures here in Indian country. And I really feel that there's a lot of work that needs to be done both together and to learn from each other to really advance this role in today's world and society. So I'm really grateful to be a part of these projects, this work, to build partnerships in this space and to be able to learn from everyone that I've been able to meet here. So yeah, that's why I'm drawn to maternal and child health. So now I'll quickly talk about some of the projects and programs that we have at NIHB right now. So currently we are working on 3 major maternal and child health projects. The first one being the Tribal Prenatal to Age 3 Policy Agenda, and this is a project funded through the Pritzker Children's Initiative. So here we are really looking at all environmental and social factors that contribute to the health and well-being of tribal families and to advance the health and well-being of children ages prenatal through 3. This is a really robust and comprehensive policy agenda that addresses a lot of cross-sectional things like environment, education, early childhood education, parental leave in the workspace, engaging with programs like WIC, things like that, just to give a holistic view of, a lot of the realities, resources, and resilience points in tribal families and communities. Secondly, we work on the Tribal Maternal Mortality Review Committee project, which is funded through the Centers for Disease Control, CDC. This project explores the feasibility of implementing tribal maternal mortality review committees, both at the local, regional, or all at the local, regional, state, and national level. So we've been engaged with this work since about 2019, and our first meeting on this was 2020. But I'll speak more on this a little bit later in the presentation. And finally, we worked on the Hear Her campaign with the CDC. This is a national campaign the CDC has led on raising awareness around maternal health warning signs before, during, and after pregnancy. And the CDC had built out a specific American Indian Alaska Native arm of this campaign, but they quickly recognized that this type of work needs to be localized to address the diversity in both histories, cultures, and needs across Indian country. And so we support 6 grantees for this project, and I'll speak more on this too. So firstly, with the Prenatal to Age 3 policy agenda, as I mentioned, it's a comprehensive policy agenda, and it really addresses a lot of current priority areas for advancing the health and well-being for tribal families and their children from ages prenatal to 3. Right now, where we are at with this project is in the dissemination phase. So our senior policy analyst, Carrie Fields, has really taken lead on this project and has completed a draft policy agenda. Yesterday, we actually hosted a listening session to get some more feedback and insight on this policy agenda. But I invite you all to take a moment to scan this QR code. It should lead you straight to our website where you can find the draft policy agenda. At this stage, we are inviting any feedback to be given in a written form and to be submitted back to Carrie. So there'll be more instructions on that through this QR code on our site. But we really want to make sure we're getting as much information, perspectives, want this to be as comprehensive as possible so we can actually, move forward with selecting some of the priority policy areas that we can continue this work with. The Pritzker Children's Initiative has done similar projects with other communities and agencies. But throughout my experience working with them, we really realized that this is going to look very different for tribal families and communities. So as I mentioned, we want to gain as many perspectives to reflect the diversity across Indian country. So if you have the availability, interest, or any feedback that you'd like to share on this, I invite you all to submit written feedback through this. Next is our Tribal Maternal Mortality Review Committee's project. As I mentioned, it's exploring the feasibility and need for developing tribal maternal mortality reviews at the local, state, regional, and national level. So as some of you may know, a lot of the ways that the US has been addressing the maternal mortality and severe morbidity crisis is through state-led maternal mortality review committees. However, this process often is not transferable to the root causes or leading factors in and around tribal communities. So there's been a big interest in gaining more tribal insight on how to best conduct these types of reviews and to move this work in a more culturally congruent way. So I have been a part of this work for about a year now at NIHB. And when I started, we were actually in the final stages of finalizing our 2023 convening, which I'll speak on in a moment. Before I started this project, we began work with the CDC for this back in 2019. And in 2020, about a month before COVID, we had a national meeting with 11 area Indian Health Board representatives. And through that meeting, they actually developed these 4 potential models for what this work might look like. So again, representative of all different levels, the tribal level, area level, a blended tribal state level, as well as a national level. And these were kind of the foundational models that were used to conceptualize what a tribal maternal mortality review may look like. In our 2023 convening last November, we recognized that although these are kind of a foundation for these conversations, there's much more work and expansion that can be done to really address the severe mortality and, the mortality and severe morbidity crisis for tribal women and birthing people. So this is kind of the depiction of the models that we have, but I do want to state that this is a fluid process, and these models may serve as like a basis or a starting point for the conversation, but the conversations are still ongoing. And as I mentioned back in November, we had our 2023 convening on the Santa Ana Pueblo lands in New Mexico, and that was a wonderful convening where we gathered all maternal health experts in the field to kind of speak on their experiences, to give insight, and to learn more about what this process may look like and need. So this is just a photo from the convening, and it's one of my favorite photos that really shows the beautiful scenery that we were in to have that convening. It was really great to have a lot of conversation, discussion, to share time with each other, to visit with one another, and bring in a lot of different perspectives to show how we can move this work forward in a good way. These are some more photos. So we did have a panel of tribal maternal health experts to share their experiences and where they feel the priority areas are now for advancing this type of work. We also had several small group discussions that talked about the process, the scope, the vision really overall for what this may look like, and share experiences for those who have served on state-led MMRCs, what their experiences were and how we can improve that process overall. The final project that we work on is the Hear Her campaign. As I mentioned, this is a national campaign to raise awareness around urgent maternal health warning signs and also support communication between patients and their providers pre, during, and post-pregnancy. The CDC had built out an American Indian and Alaska Native arm for this, but it was a pretty small focus, and was not representative or reflective of the diversity across the communities. And so they decided to partner with NIHB. And our role in this is to provide sub-awards or grants to, currently we have 6 grantees that we work with. We also provide technical assistance for helping them localize this Hear Her campaign in their communities to address their community needs and address all of the root causes for some of their pregnancy-related warning signs that may lead to adversity later on. We will be hearing from one of our grantees, Mashantucket Pequot Nation, next in our presentation. And yeah, this has just been a really great project to work on. It's been wonderful to see how all 6 have similarities and a lot of differences across their projects. And it also showcases the need for these types of sub-grantees for localizing, national campaigns, the importance of having the community see their own people reflected in these types of health communication campaigns. So I've learned a lot through this project, and it's been wonderful to work with all 6 of our grantees. As I mentioned, we have 6 grantees, so we currently work with Tuba City Regional Healthcare Corporation, Maternal Pequot Nation, the Muscogee Nation Department of Health, Winnebago Comprehensive Healthcare System, Dene College, as well as Santi Health and Wellness Center. So working with all 6 of them across the country, addressing their regional and national needs related to this work has been wonderful. And I'm really grateful to have been a part of the process of seeing projects from their infancy to now completion. It's been wonderful. The last thing I will end with is we did have a little bit of a speaker change. We were hoping to have child trends speakers join to speak on syphilis and congenital syphilis and the work that Child Trends is doing around this. However, due to some family related issues, they were not able to join today's session. But I did want to share a little bit about Child Trends. So they're a research-based organization, and they do have an Indigenous health arm that they are building out currently as well. And this is really led by Deanna Roundhim with the Cherokee Nation. She's a wonderful researcher and has done a lot of great work in tribal family and early childhood health related research. They recently had a national webinar and listening session on their work around syphilis and congenital syphilis. But I did want to share their information. If you scan their QR code, it'll take you straight to their Indigenous health kind of like sub website where they have their current projects. They feature a lot of their researchers who are working on this subject. And there's an opportunity to get in contact with them if you'd like to learn more about their work around syphilis, congenital syphilis, and beyond that, just generally research projects that they work on. And finally, I'll just end by saying thank you again all for joining today's Institute. As we know, it takes a whole community, a whole bunch of people together to promote tribal health in general, but definitely maternal and child health work. There are so many cross-cutting issues, so many different areas that we can all contribute to. And I'm really grateful to be an ally in this space and really grateful to be a part of the work that I've been able to do here at the National Indian Health Board. So thank you all again for your time and for sharing that with us. And I look forward to continuing the Institute. So now I will be inviting Fatia Richardson and Shaquanna Sebastian, to present their work on the Pequot Strong Mom project. And I will go ahead and give access so you can share your screen as well.
Is my screen shared?
No. There you are. Can try now. Yeah, we can see it. Great.
Perfect. Okay. Okay, so hello everyone. My name is Shaquanna, um, and I am presenting with Fatia Richardson. Just want to thank Preetha and her team, for having us a part of such a great initiative. We got really great feedback from our community, so we're excited to share with you all. So just an overview, the Mashantucket Pequot Tribal Nation is one of 3 nations in the United States selected to collaborate with the Centers for Disease Control and Prevention and the National Indian Health Board to amplify mothers' voices in order to reduce maternal mortality as a part of the Hear Her campaign. So we selected 5 Pequot mothers and we decided to name it Pequot Strong Moms. They're just full of resilience. Each of them were able to tell their stories about their pregnancy and if they had any complications and what they went through. And it was also a great gathering between Pequot mothers, which essentially will lead into them leading their own Pequot Strong Mom group here on the reservation to just help with, anything that up and coming mothers may need or just moms right now. So we have Cassandra Mayette, Brianna Andrews, India Robinson, Fatia Richardson, who is here with me today, and Dominique Beltran. So Fatia Richardson, we're going to show her video, and then afterwards she can kind of explain, give a nice little intro to herself and her story as a strong Pequot mom.
Going into the emergency room and they monitored her for a little bit. Everything came back fine. She was healthy. Of course, she proved me wrong.
Hey, Shaquanna, I'm not sure that the sound is sharing out for the video.
You can't hear it at all?
No, we're not able to hear.
Oh no. I'm not sure how it would work.
I think it started and then it went off. I don't know if it's because maybe you went on mute.
Oh, okay. So I'll probably have to just keep it unmuted.
I think we can try that.
Okay.
Dehydrated and just
How was that?
trying to get as
That's
much
better.
rest as I can. It did help to put like crackers and water by my bed, so that way in the morning, before I like got up and started moving around and doing all those things, sometimes that would help with the nausea. So just learning to take certain steps for those few weeks, because they can be very hard and sometimes it lasts for the whole pregnancy. It's very uncomfortable, but just try to do what's best for yourself and the baby.
It's tricky, right? Because some of the symptoms, as you pointed out, could be part of normal pregnancy, like morning sickness, or it could be part of something more severe and serious,
Right.
like hyperemesis.
Yes, and that is actually a condition that my mother had. So I was very worried about that in terms of when she had that. She found out she had that when she had gotten pregnant with me. So she was in the hospital for the majority of her pregnancy. So that is definitely something that I wanted to watch out for and make sure that my sickness was just a normal pregnancy sickness versus something more.
And the fall episode later on, what was that like?
That was very scary for me just because, you know, there's all different things that can happen if you do fall while pregnant. I was lucky enough I didn't fall on my stomach. I fell on my back, so I was a little less concerned about everything. But I think the scariest part of that is just the movement of the baby, because by that point you're so used to feeling them move around, and so when that's not happening, that's definitely an alarming thing for.
I'm learning a lot as well. So yeah, thank you. This is great, great insights, and I'm glad you had the courage and the conviction to listen to your own symptoms and bring them up to your care team. And thankfully, they listened.
Yes.
And we have positive, healthy outcome.
Yes, she was a very healthy baby.
That's all that matters.
Yes.
Thank you again.
Thank you. Awesome.
So now we will hear from Fatia. I'll just keep this pause. We'll hear from Fatia and her thoughts and insights, and then we'll continue.
Good afternoon, everybody. My name is Preetha Raj. As Shaquanna stated, and as you can see, I was a part of the Hear Her campaign. Just to give a little insight of everything since the campaign has sort of ended, I guess. My daughter is now 1.5 years. She's growing wonderfully. Everything's been great. I think the video pretty much covers anything I would say about my pregnancy, but I loved this whole process. The conference that we went to was very helpful. It was nice to see all the other ideas that all the other communities had and how they kind of took the grant and made it into their own. Everyone had different ways to kind of bring attention to the mothers in their community and the babies. And so that was really cool to see. Yeah, so I'm just very thankful to be a part of such a great project. And I think it also gave me a lot of information, just being able to hear all the different stories, especially from within my own community. I didn't know that a lot of my cousins had dealt with certain things that they dealt with throughout their pregnancy or just with their kids in general after. So it was definitely a very informative and helpful project, and I hope to work on something like this again soon.
Thank you, Fatia. And a lot of the mothers as well, I wish they were here to express how this initiative has brought them together to kind of take on that maternal health instinct into our community and gather everyone. So then I'll move on to our Pequot Strong Moms timeline. We started the planning sessions and the website launch October through December 2023. January and February, more of the filming of the Pequot Strong Moms documentary, which was just a great process, just kind of brainstorming ideas and how we're going to roll out this campaign. And in March to June, we launched our social media campaign, introducing the mothers, and then kind of just highlighting their stories. And then in June 2024, we had a community baby shower, which it was so great, such a great turnout. So many expecting moms, some who had literally just had a child, probably just a few days before our baby shower. They were able to come and get great gifts and just anything that could help towards their journey into motherhood. So that was really great. So all together from the community, we got great feedback. We also designed our own shirts, which the logo was in the beginning that you saw. And yeah, so now we're just trying to see how we can, from our community standpoint of view, of how we can continue to have this group meet and kind of make waves in the community, to help any mothers that are starting out who don't really have that sense of community or that strong base of support that they need. And that really launched a great initiative within our tribe just from, participating in the Hear Her campaign. So just want to say thank you to Preetha and the team. Thank you.
That'd be great if we did like
And then we just want to say thank you to everyone who listened. Please follow us on Instagram and X. You can scan the QR code to follow us directly to the Instagram link. And you can keep up with all of our updates, and we'll probably be posting more once we get everything situated. So thank you, everyone.
Thank you so much, Shaquanna and Fatia. It was great to hear an overview of your project. So now we'll just open it up for questions and answers, Q&A session. So please submit any questions you may have for our speakers and the project now. We did have one question roll in. I'm curious about if folks with Pequot Strong Moms project work with WIC at all. So yeah, if you want to.
So we haven't worked with WIC. I will say we do work with a lot of local organizations that actually attended our baby shower, which is great. We have a really great relationship with local towns and just surrounding neighborhoods that are always in our community, and we've garnered a great relationship with them. But that is a great idea, and I can bring that up to Dr. Vora.
I believe the lady from TVCCI was there though.
Oh, okay.
She was at the community baby shower.
I can't see the question, so I don't know if they're like commenting or anything, Preetha.
That was the only question we had run through, but we'll keep it open for a little bit longer if anyone else has any questions for our speakers. And yeah, I'll add one more thing. So the conference Fatia was referring to was our National Tribal Health Conference that NIHB hosted in Rapid City back in May this past year. We had a session where we invited representatives from all of our grantees to come together to share about their projects, kind of where they were at, any materials that they made, things like that. But also it was a wonderful networking session. Everyone was able to kind of meet together, share resources. And as Fatia mentioned, it was really great to see how, things like t-shirts were sort of similarities through the projects, but how they came about, how they were being used in the community looked very different. And then other little elements of the campaign that were really adapted to kind of move the work forward for their communities and really reflect community needs. So that was a great session, and I'm really glad Shaquanna and Fatia were able to meet in person then, but also it was great to be with the rest of our grantees.
Yes.
And just a little shout out from Dr. Bora with Mashantucket, just saying, thank you to all of us on the team and for the grantees for this work, and way to go, Shaquanna and Fatia. So thank you, Dr. Bora, for that.
Thank you, Dr. Bora.
Thank you, Dr. Bora.
Great. If you have any other questions or yes, as Shaquanna said, invite you all to connect with them to learn more about their projects and this campaign, but feel free to continue rolling in the questions as we move forward with the webinar. Now I will invite our next speaker if she's available. We are running a little ahead of schedule, but Tess to join and to speak on her subject of data sovereignty for advancing maternal and child health.
Hi, yes, I'm available. It won't let me share my video. Is that okay?
Yes, no problem. I have your presentation ready to go. So let me just share my screen. All right, just let me know whenever you're good to advance.
Okay, that sounds wonderful. Well, thank you all for having me here at this really important event today virtually. I'm joining you all from Detroit, Michigan today, where I've been attending a Robert Wood Johnson Healthy Children and Family Summit, but I usually reside on Coast Salish territory in Seattle, Washington. And I'm excited to be here to talk about data sovereignty for maternal and child health promotion. My name is Tess. But the next slide has a little bit more about me. Great, thank you. Like I said, my name is Tess Abrahamson-Richards. I'm an enrolled citizen of the Spokane Tribe, which is located in what today is known as Northeastern Washington State. I'm also a descendant of the Colville and Coeur d'Alene tribes, all on my mother's side, and I'm English on my father's side. These photos represent some things about me. I'm a daughter, granddaughter, mother, sister, cousin, very proud auntie. I work as the Director of Data Sovereignty at Hummingbird Indigenous Family Services in Seattle, Washington. We have an Indigenous doula program. We have early childhood home visiting and family connections program. And we have a guaranteed income pilot program for perinatal and early parenting Indigenous families. We serve primarily American Indian, Alaskan Native, Native Hawaiian, and Pacific Islander families in King County, which is this county where Seattle's located, and southern Snohomish County to the north of us, and Pierce County to the south of us. And I usually say that I have the fun job of like lead nerd supporting our programs and our awesome direct service work through our data evaluation and data advocacy efforts. And that's our team on the lower right. I'm also currently a PhD candidate at the University of Washington School of Social Work, where I study intersections between Indigenous reproductive justice and governance systems. I especially like to look at how tribal and state governance systems interact around topics like parental leave. And like I said, I'm a proud nerd. So my coworker gave me the same birth nerd sticker that's on the slide. So I was like, oh, that's perfect. And yeah, so again, thank you for having me. We can go to the next slide. So I'm gonna, in this presentation, talk about why data stories matter and why it matters who tells them. Talk about expanding our understandings of Indigenous data sovereignty and governance in both tribal settings and non-tribal settings like urban Indigenous communities, Pacific Islands, and so on. And then finish up talking about the relationship between maternal health promotion and data sovereignty. And then we'll have time for questions and discussion. So if you think of questions throughout, feel free to chime in as I'm going, and maybe Preetha can help interrupt me if I don't see it right away. I'm happy to answer questions throughout and also at the end, and also just to hear from you all. I'm sure there's folks here who have a lot of experience thinking about these topics and folks that it's new for. And so you can never tailor your presentation to exactly what everyone's interests are. So I always like that opportunity for discussion at the end. Next slide. So like I said, I wanted to start with some motivation about why data matters when it comes to maternal health promotion and why we need to tell our own stories as Indigenous people and communities, with an example around maternal and infant health in Washington state. Next slide. And thank you, Preetha, for running my slides for me. Because I'm traveling, I don't have my usual monitor set up, and so this is very helpful. So the data in this bar chart are drawn from a report published by KFF, Kaiser Family Foundation, on national pregnancy-related maternal mortality by race. And I don't like that that it excludes the rates for Pacific Islander, Latinx, and Asian people, because as a Native American person, we know we're often also excluded from the data, but that's the data that is presented here. And what we have is the overall national rate of pregnancy-related maternal mortality. In the dark green, the rate among white Americans in the lighter green, the rate among Black Americans in the lighter blue, and the rate among American Indian and Alaska Native Indigenous birthing people in the darker blue. And these data represent 2016 to 2018. And pregnancy-related maternal mortality is one measure of maternal mortality. We know that you can also look at pregnancy-associated maternal mortality. You can look at overall maternal mortality. But in general, you would see the same kind of trend nationally for these four groups. And this graph likely is not very new to most of you based on information that you might have seen about this topic, either in data-related presentations or in the news and so forth. But my question for you is how you would guess that these rates would look in Washington state based on whatever you might know about Washington state, either policy-wise, sociodemographically, other things you might know about our state of Washington. Like, do you think that these numbers would look about the same? Do you think they would look different in any specific way? Maybe just think about that for a second, and then Preetha could click to the next slide. So this is what it looks like for Washington state for this pregnancy-related mortality rate outcome. And this was pretty shocking, I guess, to many of us who saw this Washington state data when it was released, although this was the second report they put out that looked pretty much the same. But when we look at this, we can obviously see there on the far right that for American Indian and Alaska Native birthing people in Washington state, the pregnancy-related mortality rate is astronomical compared to other groups in the state, but also compared to what the data appeared to look like nationally. And these data were produced by the Washington Department of Health, and they do reflect slightly different years. They reflect a little bit before and a little bit after the KFF data, so 2014 to 2020. But the national rates from other sources, it looks pretty much the same. We know 2020 was obviously an important year where we saw a rise in maternal mortality for everyone nationally, but for Native women, especially nationally. So that is an important data point. But even with COVID and 2020 in mind, we wouldn't see nationally anything like what we're seeing in Washington in these data. So when I saw this data, after just being kind of sad and sitting with it for a minute, my question really became, do these data reflect something that's just especially bad that's happening for Native pregnant people in Washington? Or do these data point to something else? Like, is our data collection for American Indian, Alaska Native women in Washington better than it is elsewhere? Like, are we picking up maybe something that might be happening elsewhere where data collection is just not as good, where we don't have the same level of Native representation on our maternal mortality review committees? Like, could it be that? Or is it something else that's going on that I haven't even thought about? I don't know. And nobody, I don't think, exactly knows the answer to that question yet, but I do think it's worth asking. And I also want to pause for a second and make it clear that I would never advocate for like a race to the bottom for us to have the worst statistics, or for this graph to undercut the seriousness of the ongoing maternal mortality crisis that's affecting the Black community. And hopefully that doesn't even need to be said to this group, but I always think it's important to name, because the systems that we exist within often encourage us to to think in that way. And that's not true, right? We're all in this fight together. And also like racial categorization in general erases the experiences of multiracial people often. And statistics are just one tool for our advocacy work and our work in general. They're not necessarily capital T truth. Anyway, so I share this graph as motivation for today's discussion, because I do think there are some serious data issues nationally when it comes to our ability to know and to trust that our experiences as Native people are being documented sufficiently or accurately, let alone whether appropriate action is being taken when alarming data like this are revealed. Like we've seen too many times that national maternal mortality statistics have been released that have excluded us altogether. And there's a pretty prominent case within the last couple of years when the CDC put out their maternal mortality by race data and it excluded us. And they said that they didn't have the data, but it was like within the same week, there was a group of academics that put out a maternal mortality publication using the CDC's data that did include us. And that was the paper that really showed how much our maternal mortality rates went up during COVID, especially in 2021, when for the first time, Native women did have like the highest rate nationally of any racial ethnic group of maternal mortality. And so we do need a lot more accountability around data collection and data reporting, and a lot more Indigenous leadership in those spaces, which is what NIHB is working on and so many others. And these data issues, I also want to say, are not just around maternal mortality, right? They're related to maternal morbidity and maternal health overall, maternal mental health. We have the same kinds of issues. This is just one example. I know many of us were at the Maternal Child Health Epidemiology Conference in Seattle the other week, the City Match Conference, and I went to a presentation there on state level maternal morbidity in the state of Arizona, and that group had said that their report was the first to look exclusively at American Indian, Alaska Native maternal morbidity at the state level, which again, it's like surprising and then not surprising, but definitely not acceptable or what we want to see happening from a data standpoint. And so I also think we know that if Indigenous people were involved robustly in maternal child health data leadership at the state and national level throughout the United States, that these same data gaps and big question marks and unknowns, like they wouldn't exist, right? If we had that leadership across the board, the data landscape and the information landscape would look a lot different. And then what about the more important step, which is turning data into action? Like, would this graph on the right be getting more attention, be getting more resources, and be getting more commitment to action if we had more visibility, more representation, more leadership opportunities in the maternal health space. Okay, we can go to the next slide.
Yes, we did have a question.
Oh, we had a question. Great.
So the question was, what type of data collection do you use? Excel with variable points pertaining to prenatal visits, weight gain, GDM, etc.
So like what would I recommend, or like what do we see the state doing?
Bernadine, if you want to just clarify if that's Tess's recommendation or what is being seen in the data that's being collected now.
I guess I can start to say that like in some of the data resources we've seen, like I mentioned, Arizona, they're relying on a lot of state administrative data. And I think in Washington, we're often relying on the same thing. And so those are healthcare provider records, birth records that the state is able to use for like surveillance. Preetha, did you see the follow-up?
Yes, so I think Bernadine, if you're able to unmute now, I believe you have access to.
Right now?
Yes, we can hear you.
Okay, perfect. So my name is Bernadine John. I am the diabetes coordinator here at Navajo area. So one thing that I'm doing with our diabetes and pregnancy group is standardizing a workbook that we have those variables. And basically we're looking at diabetes and pregnancy and pre-existing diabetes. So I was just kind of going back to ask, what type of data are you capturing for your statistics here? How is that data being captured, basically, is what I'm asking. And
Oh, okay.
I totally agree too. It would be good to compare the different tribes and exactly what you're pointing out. What are we doing better, or what do we need to do? It's just amazing that I'm really grateful to listen to your presentation.
Oh, thank you so much. And thank you for raising this important issue, which is around like kind of like standardizing our data collection, but also like reforming it, right? Because there might be standard data collection practices that we think don't work well or were created, you know, without like a strengths-based perspective or something like that. But in terms of resources around like how those type of data are typically collected, I'm not sure, Preetha, if you want to speak to that at all too, like if your team has done any work around collecting those type of resources for tribal communities. Otherwise, I can probably follow up afterwards when I have a second to really think about like, okay, like this is what PRAMS does and this is what the state does, and pull that together for you. I'd be happy to. But yeah, Preetha, do you have any thoughts there?
Yeah, so from our kind of work with CRAMS and just the MMRC work in general, so a lot of the data points are being pulled from prenatal visits for sure, weight gain, and some of the just general like hospital notes or visits from that. But in terms of like I think the issues with data collection is really just accessing the different, navigating the different data sharing agreements for those. So those can kind of vary state by state or with various tribes for that. So sometimes the data is inconsistent in what's being collected. But I kind of agree with Tess that there is a little bit more work that needs to be done in terms of like really addressing what those specific data points are for at least for MMRC reviews.
Great, thank you. So maybe a new area of work for us all to be in conversation about as well, like what tools we're using and sharing those resources across communities as well. But I'll keep going and we can continue talking as well as we go. So I think we're on the data sovereignty slide. Yes, here we go. So before I talk about how this topic around data sovereignty applies to maternal health, maternal and child health, I wanted to dive into data sovereignty itself first. And I was kind of thinking like both the word data and the word sovereignty are both words that aren't always very exciting. They're a little bit dry. And these two pictures are sort of what I think of when I thought about what we usually think of when we think of these terms like data. We think about graphs, and then we think about sovereignty. Sometimes we think about like thick legal texts covering all the like complexity of what it means to be domestic dependent nations. I don't know. I don't have a law degree, but I'm hoping that maybe we can get a little bit excited about data sovereignty today. So on the next slide, I pulled some definitions around Indigenous data sovereignty and governance. So there were some large international work groups. There was one specific large international work group that convened Indigenous communities from all over the globe for some summits and conversations around these topics. And there was at least this paper that came out from Carroll et al. In 2019, where they provided they pulled a definition from another author on Indigenous data sovereignty as the right of Indigenous peoples and tribes to govern the collection, ownership, and application of their own data. And then they define Indigenous data governance as governance. They say governance of data as an extension of the rights and practices that originate in the sovereignty of nation states. And so, and I guess in a simple way, it's just saying that like our sovereign rights as Indigenous nations to govern within our borders, I guess for us as American Indian, Alaska Native people to govern within our reservation borders, those rights that we have also extend to data. So we also have the right to govern how data are used and collected and so forth in our communities and about our communities. And that usually also brings up the question, like, what is Indigenous data? Like, what data would fall under our sovereign governance rights? And so those can include data that are like generated by Indigenous people, generated by Indigenous governments or other Indigenous institutions, data that are collected on our lands, data that are collected about our lands or about our peoples. All of those things are encompassed within that. And I would also say that these terms are not static. I think that there has been a huge explosion of conversation around Indigenous data sovereignty that's ongoing. So they're still kind of being refined. And also like tribes are continuing to write legal codes around data. And so it's a really developing area, both on the governance side and like within, I guess, scientific, academic, legal literature. Okay, I see a question popping up. Oh yeah, someone's providing some additional resources on this topic, so thank you.
Yes, we did have one question before that. I'm not sure if you can see from Elizabeth's question.
Okay, does the state of Washington use the same race variables as the CDC, single race and race alone or in combo, bridge race, etc.? There tends to be a lot of racial misreporting in vital records where medical examiners or others don't know the person or community who don't know it assign a race to the record. Yeah, thank you for raising that really important topic. That's definitely true. I do think we have better identification of Native people in Washington state, again, because there's been work by maternal child health advocates in the state who are Native to promote Indigenous representation on the state maternal mortality review committee, and pressure on the state to do better racial categorization. I can't answer specifically how that compares to the CDC and NCHS. If there are others here who want to speak to that, that's great as well. But you're right, that could be another thing contributing to differences, is that I imagine we do have better racial identification for identifying more Native people within data. Okay, cool. People are providing a lot of more data sovereignty resources too. Okay, and here's another question. Is data collection / analysis a desire you have identified from the tribe. This process is resource heavy and time consuming, and many times states, nations, independent nations are required to collect data and provide for national data sets. They are not a resource capable of collecting. I would say that it just varies from place to place. Again, I think this is kind of like framed as a question, but you're actually providing just like a really important lens, another lens to this conversation, which is like, where should like data capacity be developed and live? Like we know that like the health boards and like the tribal epicenters are in part designed to like take on some of that capacity from like a tribally led standpoint. We know there are tribes who've done a lot of work to build up data and research infrastructure, and I'm going to talk a little bit more about that as well. And then, yes, we know that like, there's this great quote from a tribal leader, Mel Tenasket from the Colville tribe. I was talking to him once, and he said like, what he wants to tell young tribal leaders is that we often think about tribal sovereignty as like these big Indian law cases that go before like the Supreme Court or that we're fighting throughout district courts. We think of these big cases and we think of that as like how we fight for our sovereignty. He said, but we don't think about how we give up our sovereignty when we enter into a grant with the federal government. And that just really stuck with me because like you're pointing out, there can be a lot of requirements that come along with the grant. And like we're here talking about data today. So yeah, a grant can require a tribal nation to submit all kind of like performance measurement data or other kind of data. And then we're not actually, our communities aren't seeing the benefit from that data come back to us. We're not seeing data come back in a usable form. And often it's like through the complexity of Indigenous data sovereignty too, right? Like if there's 20 tribal grantees under the same grant program throughout the country, and they all report the same data to their federal funder, and then they want to know like, what did you see? The federal funder might come back and say like, oh, well, we can't actually tell you because we don't have permission from all the other tribes. And then, you know, whatever you reported to us, like that's small numbers, so it's actually not going to go anywhere. I'm not sure if that's all of what you were speaking to there, but that's what came to mind for me. I see another question. Where does data collection fit on those who don't live on tribal lands, especially since more than half of our people live in urban areas? I'm going to talk about that soon, so stay tuned. Are you aware of any tribal nations that conduct their own census? I'm not. I wonder if that happens. If anybody else is aware, feel free to say so. The census changed their race question and captured a larger population of Native Americans. Will this be beneficial? I know that there was some question marks around the census data because they were including, they did expand their definition, which is great from like a kind of broader lens on indigeneity and like thinking beyond our borders. Like they were picking up people who are like from indigenous nations in Latin America, but then like there were some question marks of like from a tribal perspective in the US, how helpful is this? Like it's not necessarily enhancing our numbers and knowledge about like federally recognized tribal nations within US borders. But I'm not a census expert. So again, maybe later at the end, if we want to continue this and there's other experts in the room, we can continue that. And I'll read this next one and then I'll probably keep going. I'm really excited. Thank you all for your interest in this topic. I was worried it would be too dry. The complexity of local governments in the application of TDS is difficult. I'm assuming that's tribal data sovereignty. I would love to see the application of tribal data sovereignty at the county level, depending on the epi capacity, or maybe that's data systems, on the epi capacity of the county health department. Yes, I think we need to see a lot more knowledge and capacity building on the part of non-tribal governments at all levels when it comes to understanding tribal data sovereignty and how they are accountable to that. And I have an example I'm going to talk about later again from Washington because that's where I'm based. But yeah, thank you all. You're all very much experts in all of this too. So I'm glad this is more of a dialogue and not just a one-way conversation. So please keep it going, but I'll keep continuing here. I want to, so I think the next thing I had here was like this idea of data for governance versus governance of data. Again, this is something in that same piece by Carol et al. And has been written about by other scholars. So this idea that tribal nations and other indigenous communities have a need both to have data to engage in governance, like to make governance and programming decisions that are data informed. Like we need more information about what's really going on. Again, going back to like the example I gave at the beginning. And then that there's also the need for governance of data for like tribes to be in the position where their sovereign governance rights over data are respected and adhered to, and in which like there's capacity supports to do that work to exercise like sovereignty over data as well. And that's where we get to tribal research codes and policies. So like I mentioned, there are many tribes who have written tribal research codes. I know that the Navajo Nation, their tribal research code is available on the Navajo Nation Human Research Review Board website if you want to read an example. There's probably others out there too. That's just the one I know you could find easily. And the Navajo Nation has definitely been a leader nationally in establishing a lot of institutions and systems surrounding the exercise of data sovereignty and governance. For instance, by standing up a tribal institutional review board. So that's on the next slide. So in addition to like having laws and policies when it comes to Indigenous data and research happening on tribal lands, research review boards are another key institution for establishing research protections on tribal lands. And tribal IRBs have been really innovative in extending beyond what other IRBs have done. So typically researchers who are engaging in any kind of research with people go through an institutional review board for ethical review of their research, because after lots of research abuses that have taken place, especially like after World War II, there was seen to be a need for this. So now researchers have to go through an institutional review process to be in compliance with and to assure like that there's ethics and protections for anyone who's participating. So typically those are based in universities, or there's also like private institutional review boards that people can use. And those really focus on protecting like individual human beings. But what tribal IRBs have done is really been thought leaders in thinking about extending individual level protections to also think about like community level protections and benefits when it comes to reviewing research proposals. I'm seeing questions pop up again. Okay, I might come back to these. Oh yeah, someone shared Turtle Mountain's research protection code. I think I'll come back to the managed care question later. Okay, and like it says here, tribal IRBs have become a lot more prevalent thanks to growing advocacy, interest, and capacity for research governance. But they are not the only form of tribal research review. Anyone doing research on or about a tribal nation needs to engage in like tribal research approvals for that project. And that can be carried out by tribal IRBs or RRBs, which are research review boards, tribal college, institutional review boards, tribal governments, individual tribal agency or program leadership, often in combination with tribal government review, regional IHS IRBs, the national IHS IRB, but it's often a combination of these. So an example I give here is the research project I worked on that was partnering with tribal early childhood programs across 17 different tribal and urban Native communities. We got program or agency leader approval at every study site, tribal IRB approval at 7 sites because that was how many had their own tribal IRBs, and tribal government approval at 4 sites. So it's really the job of the researcher to do their due diligence to find out what tribal approval looks like for for an individual tribal community, because every tribal community is its own sovereign nation. They're all distinct and they have their own processes. It's not one size fits all. So I'm going to go to the next slide, which relates to what somebody just brought up in the chat, which is Indigenous data sovereignty and governance in a non-tribal context, because we know that tribal nations' role is very important in the Indigenous data sovereignty and governance landscape, but that it doesn't cover all Indigenous people that live in the United States and the so-called United States territories. There's really unique considerations for urban Indigenous communities where over half of American Indian Alaska Native people live, for Pacific Islander nations and Hawaii, Samoa, Guam, places like that, for those nations and communities, and then other Indigenous people and communities who don't have formal sovereign governance rights via like treaties with the US government. And so these communities have had to build their data sovereignty and continue to build their data sovereignty and governance powers in different ways, through organizing, policy creation, mutually empowering one another, partnership with research institutions, so that they can enhance those other institutions' capacity and understanding what they need to know when it comes to reviewing Indigenous studies. So I'm thinking again, specifically, like I work at the University of Washington. There's been a lot of Indigenous researchers at the University of Washington who have worked with the University of Washington's IRB to understand what they should be looking for when an Indigenous focused project comes across their desk, and to make sure that there's Indigenous representation or like a specific committee within that large IRB that has the expertise that they need to review studies with, say, like the urban Indigenous community in Seattle, and more, right? But like, that organizational one is a big piece often, right? So like often university researchers come to urban Native organizations wanting to partner in research. And so organizations themselves can develop policies around what approval and review of those projects looks like over and above institutional review board review. Sometimes regional IHS review boards or the National IHS Review Board perhaps can or will review urban focused studies with American Indian Alaska Native people, but I think my sense is that that's kind of up to them. Mainly they're there to serve their member tribes. But I know that I've worked with regional review boards to like request that they review an urban focused study, knowing that they might have a better perspective than a university IRB when it comes to our communities. And yeah, I guess an example of also why this matters is a recent experience that we had at Hummingbird with one of our university partnerships, and we're an urban Indigenous organization, but we were partnering in a grant with a university, and the university was supporting us with a survey. And they house like the data system where the data we're going to get entered from the survey, and they're going to help us analyze it. And we really trust our university partners, but they're working within their own big bureaucratic system. And so they passed it off to their grants office to set up like our subcontract with them. And the grant office sent us this very generic data use, like data ownership agreement that really didn't respect Indigenous data sovereignty. It said like the university owns the data, they have the right to use the data however they want forever, and you can't put any limits on it. And I know that the university has signed different agreements in the past with other tribes. It's a giant university. They've existed for a long time. They have a lot of people doing Indigenous research. And so I kind of put it back on them to say, like, what else do you have to send us? And they really wouldn't provide anything. So I had to go to the researchers I knew at the university who might have other templates. We worked with our community and cultural advisory board to like provide some revisions to the language. And we really didn't have like a legal framework to fall back on right? Because we're not a tribal nation. So we can't really say like legally you have to do this, but we could say like we're not engaging in this project if you say that you own all of our community's data and you can do whatever you want with it. And they didn't push back on our revised language in that case. And so the story kind of ends there, like we got what we wanted, but it did illustrate to me again, just like the capacity issues on the institution side that we're often running into, like we have to reinvent the wheel every time, when a more ideal reality would be that they were like, they could have sent me something when I asked and said like, yeah, you know what, actually, we know about Indigenous communities and we know what Indigenous data sovereignty is. And we have a different template that we can make available. But yeah, thank you to the person that asked about the urban context, because that's very important. And I think that a super important role for our non-tribal communities all throughout the US and US territories is just building our collective voice as Indigenous people when it comes to creating data, analyzing data, using and sharing data, and thinking again about the example I shared in the beginning around maternal mortality. There's just a lot of work being done across our communities, like say in the maternal mortality space, like to participate in state maternal mortality review committees, to stand up our own maternal mortality review committees, to hold big, powerful entities like the CDC accountable and to partner with them to improve their processes and to not exclude our data, for turning data into action, which again, I will always emphasize, and overall to have Indigenous leadership in all of these spaces and activities. Okay, I'm checking in on the chat again. Yes, Abigail Echohawk is one of my favorite people, a very dear mentor to me. And UIHI has done incredible work around here. I think somewhere in the slides, I cite them around this idea of data genocide, and everything on their website is worth reading. Aloha Nui from Hawaii. Our organization has been using specific language when engaging in state contracts. We use the, I apologize if I am going to mispronounce this, but Pa'oakalani Declaration, and work with the contract manager to work out shared/mutual use and stewardship of the products. I'm so happy to hear other nations are standing strong to protect our Indigenous property rights data and ancestral knowledge. Thank you so much for sharing that. And I'm so glad that you're here to share that perspective and example. Thank you so much. And Preetha, I hope that the chat will be saved with all these links. Please, I would definitely like to have all of them at the end.
Yes, definitely. Thank you all for sharing your resources. This is great.
Okay, I can move on to the next slide, which is just kind of this related idea that I want to touch on that I called expansive sovereignty. Other people might call it something different. So I put a quote here from Yvonne Sherwood, who's Spokane, and Michelle Jacob, who's Yakima. They're both two Indigenous scholars that I really look up to. And in a paper they wrote, they called Anting on the Front Lines. It's a great paper, but they write about this like false dichotomy or false distinction between short-term legal reform and long-term anti-colonial organizing. And they're arguing that we should not read Indigenous people's turn towards legal remedies as a surrender. It's an ever ongoing negotiation, not a giving up. And so I just wanted to kind of touch on this idea that Indigenous people have pointed out that sometimes there's like this limitation when we just accept a narrow legal definition of sovereignty, something that's like externally defined and imposed on us. When we accept that as like fully determining what Indigenous sovereignty is in the United States and in Canada and in other settler colonial nation states, and they're arguing for like rooting Indigenous governance and power in broader ideas of sovereignty and Indigenous ways of knowing that are beyond just what's recognized as our rights by the US government and its laws and policies. But they're also saying that like those are sovereign governance rights and what is like in US Indian law in the case of American Indian Alaska Native people, like that is still really important. And it's not like we have to get rid of one to have the other. but that these are just like two strategies that we've always used, right? We've always worked within the system and outside of the system to truly exercise our sovereignty. And they've also talked about needing to consider sovereignty like outside of governance altogether, or to consider political sovereignty within a more holistic view of Indigenous people and communities, in which policy and law are just one part of our society and one part of how we exercise our sovereignty. For example, like other ways of practicing our sovereignty are practicing our culture and our languages, being on the land, using Indigenous ways of knowing in our data research and in all parts of our lives. People write about like how doing art and music are part of our sovereignty and so on. So just wanted to throw that out there. It might resonate a lot with some people, and some people might be like, what are you talking about? But again, the idea for like expanding our vision of sovereignty when we're thinking about data sovereignty is intended to like supplement and go alongside the legal and governance work, not to undermine those efforts and protections, which again are still really important. And this also has relevance beyond our community. As like a liberatory practice for many communities who have faced marginalization in data and who are harmed by current systems that surround mothers and babies. Like from a data protection standpoint, there's a lot to be gained from thinking beyond the current institutional review board system that is very institutionally based. And there's a lot more we can do that's more rooted in like community-based practice. Another one of my mentors, Dr. Myra Parker, often talks about an example that she saw of an urban Asian American community that utilized a tribal IRB as their model to stand up their own community IRB for researchers who kept, again, coming to their community to partner with them, which is cool. So people can learn a lot from what we're doing as well. Because we've been leaders in this space. And I also think this framework, this expansive sovereignty framework, allows us to think about power in our communities from an Indigenous feminist standpoint. We can think about who should be at the table when it comes to maternal and child health data issues and needs across our diverse Indigenous communities, because often the people who are doing the real life-saving work, the health promotion work in our communities when it comes to maternal health are not in formal government leadership positions. Sometimes they are, or in other institutional leadership positions. But often they're not. And also like within spaces of power, especially non-Indigenous spaces of power, they're intentionally marginalizing these people, like our Indigenous doulas, say, or whoever it might be, our maternal health advocates. And they're marginalizing our health promotion movements because they want to undermine our power, right? Like that's how colonialism, that's like an old tool of colonialism that's still ongoing. So again, we just always need to be thinking within systems and beyond systems as they exist now, to truly realize like reproductive sovereignty and truly realize data sovereignty for our communities, in my opinion. Okay, now I'm gonna move on to like kind of continuing to connect this back to maternal health promotion. Let me check the chat. Oh, okay. How does a nonprofit who serves people who, quote, identify as Native without accountability have to do with data sovereignty? Your anecdote doesn't address the question. Okay, so maybe, yeah, this goes to like identity fraud issues in Indigenous communities. Again, this is probably like a policy question when it comes to urban Indigenous organizations, like how we each are sort of dealing with that issue of like proof, you know, like I guess in Seattle, we have like the Chief Seattle Club, which does services to people who are living homeless in Seattle. And they do require like tribal identification probably because of grants they receive or maybe for other reasons. Whereas like our organization, we're serving American Indian, Alaska Native, also Pacific Islander communities. Each community, like not, Pacifica communities, are not all using like CDIBs in the same way. We also, maybe for ethical reasons, aren't requiring like certain like proof of identity, but maybe we're asking more expansively about identity. We have a guaranteed income pilot program, and that was a big question I think people had, that like, since we're giving out like money and we really want to make sure it stays in our community, how would we attend to this really complicated issue, which I'm sure everybody here knows has like caused a lot of hurt in different ways. And so we did ask for identity verification, but a little more expansively in terms of like, do you want to provide like a tribal ID or a CDIB or something else, or like, how can you speak to your identity? So providing accountability around that in a way that feels a little more, I guess, like people feel a little more held and not surveilled, if that makes sense. But yeah, I think each urban Indigenous organization would address that through their own policies. And I guess you were probably talking about the example I gave around like working with the university. Yeah, again, I think it's complicated because it is like a very emotional topic for a lot of people. I think it is really important to protect our data sovereignty in an urban space. So I think I'm just rereading your question because I'm trying to see if I am understanding it correctly. But yeah, I don't think our work to like exercise data sovereignty in an Indigenous space is undermining the work that tribes are doing. Yeah, if you have more to ask about that, I'm happy to continue that conversation. Okay, let me check anything else. Okay, so data sovereignty and maternal health promotion. We could go to the next slide. So I've touched on this a little bit already, but basically this idea that our communities need information to inform programming and policy, and just the fact that there's a huge lack of relevant maternal health data currently. I mentioned that City Match session from where they said this was the first ever study of severe maternal morbidity at the state level to focus exclusively on Native birthing people, and how I was like, wow, really? Like no other state has taken the time to do this yet. Another area of work or another space that I do a lot of work in is around paid family medical leave. And if we looked at a map of paid family medical leave in the US, I actually wish I would have included it, but I didn't. But what you would see is that there's about 13 states plus the District of Columbia that have paid leave to date. We do not have a federal paid leave policy in the US. But what we don't see in that map of like the 13 states is a map of like what paid leave looks like in like a tribal nation context, for example. And that's something that like I'm kind of working on in my doctoral research. But again, like speaking for Washington state, we have 29 federally recognized tribes in the state, and none of them are currently participating in the state paid leave program, which is resulting in a big inequity in paid leave benefits access for those who are working for a tribal employer versus a non-tribal employer. And that's for complex reasons. Like I'm not here to say like the tribes should have said yes to a state level policy right away, but we did see a big breakdown in the process of like passing and implementing paid leave in Washington, in which the state really did not do any work to engage tribes. They didn't host government to government consultations. They didn't even really go to communities and talk about like, what does this cost? And we know that paid leave is a very, very well supported, like evidence supported policy for promoting like maternal infant health. It has very consistent outcomes when it comes to positive outcomes, when it comes to a lot of maternal infant health outcomes. And it's not a surprise that like having 12 weeks paid at home with your newborn is good for everybody. That's a main thing, like one of the main things paid leave covers is that birth and bonding leave that can also be used for other health and caregiving reasons. But in talking with other states, it's a pretty similar reality. But again, that story is not being told. And so this conversation about paid leave is pretty skewed when it comes to our community isn't speaking to intersectionalities in our community. Like we know now in Washington, like Native people in urban areas have a different level of access to these benefits than people on tribal nations, and that from tribe to tribe, like some tribes have their own policies and some don't. But again, when we're not the ones telling our story, we'll just see like the same map of the 13 states over and over again. Here's where I quoted Abigail and her team's work on data genocide, which is this idea that like colonization has always sought to erase Indigenous people, either literally, like physically, or in any other way, like from visibility and from our voice. And it's one aspect of that is data genocide, or erasing us from data. And like I've already said several times, but super important to me, like we also need to balance the need for data and research with the need for action, because data collection should always be in service of a larger purpose, and it should always be tied to policy, to programming, and to community action. It shouldn't just be data collection for data collection's sake, or like what researchers often do, which is like they finish a study and say like, so we need to do another study. That can be true, but it also needs to have like policy and on the ground relevancy. And then because when it's not, like there can also be this other unintended outcome where like say there are like negative statistics or like hard statistics coming out about us, like society will like kind of consume these narratives of pain about our people without doing anything about it, or without like especially like diverting resources towards our communities to address those things ourselves. So there's a lot to navigate. But I think that our best protection and advocacy comes from Indigenous leadership in these spaces throughout like the data and policy life cycles. And then I think this is my last slide, is the next slide on data for governance. Or sorry, on governance of data, which is that when we're working with Indigenous data or working with other people who are working with Indigenous data, we often have to advocate for protections around Indigenous data sovereignty and governance, because there's a lot of people working within large data systems who aren't aware of these topics or haven't taken the time to learn. One sec. Okay, I just needed some water. So when I first came to the University of Washington to do my PhD, and I wanted to look at paid leave, I became aware of this large data resource that the university houses that's made up of state administrative data. And so state administrative data is just like data that the state has collected, not intended for research originally. They just collect it as part of like state governance. But then like in this case, like has become a research resource. And so it includes like birth records data, unemployment insurance data, which is like data that employers have to report on wages. So it contains a lot of wage earning data for almost all workers in the state. And so I was interested in how this data set could be used to look at paid leave. And I like went through a long process to get access to the data and start looking at it. And what I saw is in Washington state, we collect tribal affiliation data on our birth certificates. And so I saw that the state gave the university birth records data, including like tribal affiliation data for Native birthing people in the state, which they shouldn't have, because that's very clearly an example of tribal data, right? Like it lists individual tribal names. A researcher could, if they wanted to, nobody did, but they could have like run an analysis looking at a single tribal nation or multiple tribal nations using that data without any tribal oversight. So luckily the researchers I was working with, they understood the problem right away and like deleted the data and talked to the state. But that was a really clear example of where like the state institutional review board that was tasked with overseeing that data, like they clearly didn't have a good understanding or working definition of what is Indigenous data and like what their responsibilities are around Indigenous data sovereignty and governance. And like, so we always need to, like it says here, like advocate for those protections. And the good news is like there's lots of great work happening to bring Indigenous leadership and governance into the very like foundations of maternal health data, which is what I'm focusing on today because of the theme of this institute. So again, I've mentioned it several times, but the MMRC work that's being done is a good example because having Indigenous leadership on maternal mortality review committees or tribes standing up their own Indigenous specific committees is like very deep governance of data in action because it shapes what even become data. Like somebody asked earlier, like, oh, well, how are you classifying race? Like how many people are getting missed? Like that shapes like what even the data will look like once you have them, let alone how they are used. And the stories that are told with them. And it also builds our community level capacities in regards to like our awareness of issues like maternal mortality. And it helps us build relationships with those like within state governments and elsewhere who are positioned to partner with us on taking action to remedy inequities. And also it builds our capacities with like data related expertise and like thinking critically about data. So I think that's all I had. The next slide says thank you. Time for discussion. We've already had a lot of great discussion, but if there's other comments or questions, I'm happy to continue.
And if you're interested in just speaking aloud to the group, going off mute, just go ahead and raise your hand and I will take you off mute so you can speak to the group. Tess, I also wanted to just double check that the managed care health plans question was.
Thank you. Thanks for coming back to that. Yes. Okay, so how can managed care health plans assist tribal communities to support data sovereignty? So thank you for that question. I just felt like in the flow, like I needed to give it more thought, but actually I think we did touch on that a little bit in terms of like, I think one key area is just like building internal capacity and like a deeper understanding of like those two topics I ended on, like governance of data and data for governance. So MCOs like are generating a lot of their own administrative data, health records data, right? Like, is that data representing Indigenous people? Is it representing Indigenous people accurately? And then is that data making its way back to community? If that data is being shared with external researchers who want to do like large health analyses, is there tribal governance involved if you have Indigenous data that's subject to Indigenous data governance within it? And do you have like Indigenous leadership in each stage of that process? Would be, I guess, where my head would go first to think about that. Yeah, I hope this was useful.
Any other questions for our speaker? Thank you so much, Tess. This was such a great presentation and generated a lot of thought and clearly a lot of resource sharing as well, which we love to see. So thank you for that.
Yes, thank you all. I'm so grateful. Like this was such a lively discussion. It's always, you know, when you're presenting, especially virtually, just knowing that like people are engaged with the topic and like providing me things to think about and learn is so enriching. So thank you. And the next like last slide is my contact information, but probably you could get access to that later as well. But yeah, thank you all so much for having me.
Thank you again, Tess. We did have a couple questions roll in. Just one from Natalia, apart from the KKF source on pregnancy-related mortality rate, are there other studies being conducted to compare the data that you know about?
Yeah, so the one I mentioned, I'm typing as a response to that. Toma and de Klerk 2019 is the like academic paper that I mentioned that came out when the CDC put out their own data that didn't include Native people, but that Toma and de Klerk paper, if you research it on Google Scholar, should pop up. If it doesn't, I'm happy to email it to you. That was the paper that showed nationally rates by race that did include American Indian, Alaska Native women. I can't remember if it had, if they separated Pacific Islander from Asian American, which is also a really important issue. But that's the paper that shows the rates through, or it probably wasn't, I don't know what year I put, I think I put the wrong year, but it had, because it had rates through 2021. I think it came out in 2023. But you should be able to find that one. And then I haven't seen anybody else really like putting out a lot of national level data, but I haven't looked super recently either. And yes, Leonie, thank you. Yeah, Toma and de Klerk 2023, not 2019. I'm just tired. Okay, and Elizabeth put a resource, points to federal law, which upholds the recognition of tribes as public health authorities and their right to access data about their populations. Yes, thank you.
See, Christine just added another resource. It looks like a CDC resource on maternal mortality for American Indian Alaska Natives. So thank you all for sharing your resources and links. It's great to see. We have another question that just came in. Having worked in a state where there were maternal deaths reviewed in the MMRC where the subject was AI, but the public report did not call this out, and these deaths were categorized as not statistically significant. Is there any guidance to state EPIs about including these numbers and noting their ethnicity?
Do you want to answer that one? Based on the work you all are doing? I just feel like there's a lot of leadership coming from your project in this space, but yeah.
Yeah, definitely. So this is kind of a common issue that we see a lot with the state-led maternal mortality review committees. We're often seeing trends of people saying like, the numbers just aren't there, they're statistically insignificant, which definitely is not the case. In some of our MMRC work right now at NIHB, what we're looking to do is kind of work beyond the state EPIs and engage techs more, again, recognizing their role as public health authorities and trying to address that. There was an interesting kind of conversation we had with Alaska as well. This was at the City Match conference as well. So in Alaska, with their reviews, they de-identified the tribe and ethnicity of the cases being reviewed because the tribes there are very small, and then they were worried that the cases, families, people would be identified through that. But that being said, there's a gap in the recommendations that come from the reviews. So without knowing, which tribe the case is from, the person who has passed on is from, then you can't give accurate recommendations. You can't address, like the environmental causes of that outcome as well. So we're working on figuring out how we can, revamp the Maria system and the PRAM system and just all the systems in general to kind of be consistent with how they're reporting on ethnicity, and even, going down to the level of listing tribes, if that is of value to the tribe, in creating better recommendations for addressing maternal mortality and severe morbidity. But this is really, at this stage, it's kind of varying state to state on how to move forward with that. But I do want to acknowledge that, yes, this is a major barrier to the work. that statistically insignificant kind of phrasing. We see that being reflected in Native Hawaiian and Pacific Islander groups as well. And it can be really detrimental to continuing getting the numbers and the proper data to address the crisis too. So yeah, this is something we're exploring a little bit more with our CDC team as well.
Awesome. Thank you again for having me, Preetha. I have to jump off now. But yeah, thanks to everyone too. And please reach out, keep in touch if you'd like to.
Thank you so much, Tess. This was, like I said, an amazing presentation and a great discussion. Thank you everyone who contributed to the questions, answers, and discussion portion. I'll be sure to share all of our speaker information out as a follow-up for this session. But yes, please connect with Fatia, Shaquanna, and Tess, and then our next speaker as well, Chelsea Randall, with the Great Plains Area Tribal Health Board. And we're really excited to have her presentation too. So thank you so much, Tess. We really appreciate it. And I will go ahead and call up Chelsea. And your presentation. Yeah. And Chelsea, I'll go ahead and share my screen with your presentation.
Thank you, Preetha. Good afternoon, everyone. My name is Chelsea Randall. I am the Director of Maternal and Child Health. I work for the Great Plains Tribal Leaders Health Board. I joined them back in June of 2022. And I graduated from Colorado State University with my master's in healthcare administration. And I wanted to kind of share a little bit about myself and my personal life. On the screen is a picture of my children. The middle is my stepson, Dominic, and he's a senior in high school. And off to the right, we have my son, Trey, and he is 2 years old. And he currently goes to a Thunder Valley Lakota Immersion Montessori School. So he's definitely learning all of the culture that they have to offer here. And then on the other side is my daughter, Taya, and she's 4 months old. And so, you know, I really feel like my children contribute to my drive and my motivation for maternal and child health work. When I joined the health board in June, I was actually 8 months pregnant with my son, Trey. And, you know, a lot of my staff joke around with me because I did my orientation on a Monday. I worked a full day in the office on a Tuesday, and then I was sent into labor. And they told me, you know, Chelsea, that was a red flag. We sent you into labor. And so we always joked about that, you know, and our organization in the health board, they actually have an infant at work policy. And that was one of the biggest reasons that, you know, I wanted to work for them, because they support you and your family. And so I was able to take my son Trey with me to work until he was 8 months. And, you know, so I was extremely grateful and thankful for that opportunity, because I've never had an opportunity like that. And, you know, definitely felt supported from the organization. And so, yeah, so that's kind of a little bit about me. Preetha, we can go to the next slide. Okay, so this next slide is the Great Plains area. So currently the Great Plains serves tribes in North Dakota, South Dakota, Nebraska, and Iowa. The organization was established in 1986 and it represents 18 tribal communities in the 4-state region. Our mission is to improve the health of American Indian and Alaska Natives by identifying and understanding health problems and disease risks, strengthening public health capacity, and developing solutions for disease prevention and control. Next slide. So on here, I put a little picture of our member tribes. So currently, these are the member tribes that we work with. And like I said, we're committed to improving health outcomes in Indian country. And this just shows that we work with the member tribes through advocacy, public health education, direct care, and epidemiological support. And we provide tribal nations and tribal citizens the tools they need to improve the lives of the people. Next. Okay, so data. Data is limited. Without access to more data, we are only seeing part of the problem. Much of the data in this presentation will focus on South Dakota. This is because data on maternal child health is limited. And South Dakota provides some of the only data we have on the important issue, particularly in AIAN specific MCH data. We need more data to adequately describe the health of our mothers and babies, and more data to inform us on the actions we can take to have healthier moms and babies. Next. This slide, so this where nowhere to go. These are states with the highest percent of maternity care deserts. And maternity care deserts are counties where there is limited or no access to maternal health care. And as you can see, North Dakota and South Dakota are the top 2 highest percentages in the maternity care deserts. In fact, 3 of the 4 Great Plains area states have some of the worst access to maternity care in the country. And almost 75% of all of the counties are maternity care deserts. So 2 of the states that we currently work with are leading in lack of access or no access to maternal health care. Next. Women are forced to travel long distance for care. So a lot of the tribal organizations that we work with face this as a barrier. As I mentioned before, this data is focusing a lot more on South Dakota because we have most of the available data on MCH in the state. This figure from the March of Dimes report shows the distance that women have to travel to deliver their babies. On average, in the United States, women have to travel about 16 minutes to deliver. In South Dakota, that average increases to about 25 minutes. In Native communities in Western South Dakota, that average increases to 128 minutes or 2 hours to reach a safe place to deliver a baby. And in South Dakota, women travel 19.5 miles on average to their nearest birthing hospital. So this definitely hit home with me, looking more at the statistics, the timeframes, because I currently reside in Pine Ridge, South Dakota, and that is often considered one of the poorest in the United States, because 53% of residents that live here are below federal poverty level. And so when I was pregnant with my first son, I had to travel all the way to Rapid City to receive prenatal care. So I drove an hour and a half because I was considered high risk, and the Pine Ridge Indian Health Service Hospital here in Pine Ridge does not, unfortunately, see mothers that are high risk with gestational diabetes, preeclampsia, things of that nature. So it was definitely a barrier. And sometimes there was car issues, things of that nature. And so a lot of our moms here in Pine Ridge face the same challenge. And so a lot of them are working with tribal programs to try and get gas voucher cards to get to Rapid City. But resources are very limited here as well. So, and this is definitely a challenge that other tribes such as Rosebud, Crow Creek, Cheyenne, Eagle Butte, they all face very similar challenges right now. Next. The chronic health burden and preterm birth by county. Where care is limited, outcomes are poor. In these same areas, many moms have chronic health conditions that can complicate their pregnancies and make the need for quality maternity care and easy access to a hospital that much more important. Women with chronic health conditions may need higher levels of care because of increased and easy access to a hospital that's much more important. Women with chronic health conditions may need higher levels of care because of increased risk of complications. But in the maternity care deserts, they don't have access to care at all in their communities. Babies also suffer from this lack of access, with higher percentages being born early and needed more care in the same places where there is no local care available. Having a chronic health condition before pregnancy increases the risk of pregnancy and postpartum complications. Preterm birth, a delivery before 37 weeks gestation, is one example of a complication that can lead to serious health impacts. The burden of chronic health conditions among birthing people is increasing across the U.S. Access to healthcare before, during, and after pregnancy is important for appropriate management of chronic health conditions. At the time of birth, women with chronic conditions and their babies may need access to a higher level of care, such as specialized providers, hospitals with the ability to perform C-section births, or hospitals with NICUs. Examining the chronic health burden across South Dakota and its relationship to adverse outcomes provides information needed to make important changes that can result in targeted resource allocation, prevention, and appropriate disease management. The percent of birthing people with one or more chronic conditions was calculated for each county in South Dakota and overall. The following conditions were included due to their availability in birth record data and established association with preterm birth, pregnancy, hypertension, and diabetes, smoking, and being underweight or obese before pregnancy. The map describes the county level chronic health burden in relation to the preterm birth rate. Areas shaded in the purple have both a high CHB greater than the overall state percent and a high rate of PTB defined as greater than the national target of 9.4%. 19 in South Dakota, the preterm birth rate was 10.5% compared to 10.5% in the US overall in 2021. Next. Findings from the South Dakota Department of Health Pregnancy Associated and Infant Deaths in South Dakota. So the report from South Dakota provided limited data on the health of Native moms and babies in South Dakota, but it is some of the only publicly available data available on the health of AIA and moms and babies available anywhere. It provides insight into the health of our moms and babies and demonstrates how the health access challenges are hurting our families. Next. Pregnancy-associated deaths are increasing. So the pregnancy-associated deaths are defined as deaths of women while pregnant through 1 year after the end of the pregnancy. These deaths are increasing in South Dakota. Pregnancy-associated deaths include those of women who passed away while pregnant, during delivery, or up to a year after the end of pregnancy, independent of the cause of death, and independent of whether the fetus was delivered live or dead. The pregnancy-associated death rate is highest in Oglala, Lakota County. Next. Pregnancy-associated deaths are 4 times higher in American Indians. So the pregnancy-associated deaths are significantly higher in American Indians in South Dakota than in white residents. American Indian moms die at a rate 4 times higher than white South Dakotans. The death of a mother is devastating to her family and our communities. Pregnant-associated deaths include those of women who passed away while pregnant, during delivery, or up to a year after the end of pregnancy, independent of the cause of death and independent whether the fetus was delivered. Let's see, which one are we on? Oh, Preetha, I think one of the slides are mixed up. But that's okay. We can move on to the next one because that one looked like another duplicate. Thank you. Infant death rates are also increasing. Although the infant death rate has fluctuated over the last 10 years, there has been an upward trend. AI infants have a death rate of 10.2 over 1,000, higher than the average and higher than white infants, which is 6 over 1,000. The American Indian and Alaskan Native infants have a 10-year average death rate of 10.2 over 1,000. And so that's you know, according to the chart from 2012 to 2019, the deaths are increasing, getting closer again to 2.7, as the first graph shows in 2012. Next. These deaths do not have to happen. 83% of the pregnancy-associated deaths were preventable. 69% of the infant deaths were preventable. You know, moms and babies do not have to die. Most of these deaths are preventable, as determined by the Maternal Mortality Review Committee and Child Death Review Committee. Next. The current syphilis and congenital syphilis outbreak is harming our babies and moms. Syphilis is a sexually transmitted infection that can be transmitted to the baby during pregnancy. Babies infected with syphilis, those who have congenital syphilis, can be born stillborn, die shortly after birth, or have medical problems throughout their lives. Congenital syphilis rates are increasing nationally. Next slide. American Indian and Alaska Native infants have the highest rates of congenital syphilis nationally. Rates are as high as they were in the 1940s, before treatment was available. We only have data to 2020 at this point in the country. Next. Over 20% of the American Indian, Alaska Native congenital syphilis cases were in South Dakota in 2022. South Dakota has a disproportionate burden of congenital syphilis and has the second highest percentage of counties that are maternity care deserts in the country. Next. These deaths do not have to happen. Congenital syphilis is preventable by treating the pregnant mother during pregnancy, but treatment requires access to regular care. Congenital syphilis is preventable, but moms need to get screened through prenatal visits and receive treatment. they struggle to get that care. Next. So these next slides are going to go into the Great Plains Tribal Leaders Health Board maternal and child health programs that are working to improve these outcomes. We are committed to serving the needs of mothers, children, and fathers in the Great Plains region. We provide direct services, research, epidemiology, and technical assistance. Currently, we have 5 maternal and child health programs under the department. And those are Great Plains Healthy Start, the Wo'ohitike Collaborative Program, also known as our Sexual Assault Program, the Great Plains Tribal Maternal Infant Early Childhood Home Visiting Program, Rural Communities Opioid Response Program, Neonatal Abstinence Syndrome, and then our Great Plains Injury Prevention Program. Next. Unique community needs deserve unique design care. Indigenous women have a sovereign treaty right to receive culturally compassionate and clinically competent care. American Indian and Alaskan Native women in Pennington and Oglala Sioux counties have higher rates of preterm birth, chronic health conditions like diabetes and hypertension that can lead to increased morbidity and mortality. Additional stressors have led to increased maternal and child death rates. Empowering women through motherhood and birth can provide a healthy start for families and a way to heal trauma. Next. So the first maternal and child health program we're going to talk about is our Great Plains Healthy Start program. So Great Plains Healthy Start has been serving families of the Great Plains region since 1992. As one of the original 15 Healthy Start programs in the nation, funded by the Health Resources and Services Administration, also known as HRSA. So we actually just received another 5-year funding for the Healthy Start program. So we will be offering services throughout the 4 states up until March of 2029. And so our goals for the program is to improve women's health before, during, and after pregnancy, and help families care for their infants through their first 2 years so they are healthy and ready to learn. We have several approaches that we would like to take for this grant. And so the first one being is direct and enabling services for Healthy Start participants. And so we're looking to provide services to multiple communities to achieve the required number of participants. Because of the vast distances required to travel between communities, this dictates that services are going to primarily be delivered virtually. By including the Great Plains area, American Indian and Alaskan Native in the target population, 15% or more of the participants will be AIAN, representing communities with the highest infant mortality rate, highest low birth weight rates, and or lowest preterm birth rates in the project geographic area. And then we're going to look at doing case management and care coordinators with 2 of our case managers, training them and looking for experience in social work and or nursing. And we're hoping that they're able to provide virtual case management and care coordination with the participants and additional modalities determined by tribal health programs. And so what we're currently doing now is, because we're currently in our year 1 for this program or for the grant, we are training our staff to provide family-centered, strengths-based, evidence-based, and culturally appropriate services and health education. Currently, our Healthy Start program utilizes a family spirit curriculum and a positive Indian parenting curriculum. So we are looking to get our staff trained in that. It's a culturally tailored family support. And what we liked about the family spirit curriculum is that they are now asking for a lot of feedback from the tribal communities to kind of tailor the curriculum so they fit their tribal needs, because every tribe is unique and they do have different needs. And so we found that utilizing the family spirit, we're able now to convert the curriculum into the different languages that we service. So we do the Nakotas, Dakotas, and Lakotas. And so it's definitely a challenge because we got to, kind of learn. And it's a good learning curve for all of us, learning different languages and things like that. But it's definitely, working. A lot of our families from the previous Healthy Start programs had given us nothing but good feedback regarding both curriculums. So we were pretty happy with that. And then we're looking to provide group-based prenatal, postpartum, and parenting education. The program will implement group-based and parenting education both in person and virtually to expand upon the current program cycle's opportunities for learning. So these educational activities will lead to positive perinatal outcomes by providing participants with knowledge about critical health promotion, parenting, and child development topics, as well as creating spaces to form connections, share resources, and receive support from other pregnant women and parents in the community. And we definitely think that's a huge part in the success of the program because it's always good to hear others and hardships that they are going through, and just a shoulder to lean on another community member that may be going through the same thing that you are. It's just always good to relate to someone else. And then of course conducting research. So the organization, or conducting outreach, the organization is really good about having community events. A lot of the departments within the health board have annual symposiums. And so we take, advantage of these opportunities to go and set up program booths or present on the programs, just to bring program awareness. And that's kind of where we're at in the process with the Healthy Start program, because we are, of course, still in our year one. And then we are looking to launch services in November. And then the last piece of the grant is our community consortium. So we are looking at establishing a multi-sectoral local consortium among the GPA communities is essential and important to the ongoing recognition of disparities impacting maternal health and implementing systems change that will improve access to care and decrease adverse perinatal outcomes. So the Healthy Start program does have a program community coordinator, and they are currently in the process of inviting and selecting consortium members representing past and present Healthy Start participants. And then, of course, we are also looking at representatives from tribal public health, social service programs, maybe tribal leaders, Head Starts, WIC, other organizations of that nature that service that target population. And so the first community consortia will convene in eastern South Dakota and involve 5 tribes. Sioux Falls Urban Indian Clinic and 2 large health systems, which is going to be Sanford and Avera McKinnon, are going to be a part of the year one community consortia. And then, of course, through years 2 through 5, we hope to implement a community consortium in West River, South Dakota. And then lastly, I kind of wanted to talk about, in the past, our Healthy Start program did implement welcoming of the babies ceremonies. And we had community health advocates that were located in 7 tribal communities, and they each hosted, while our goal was to host welcoming of the babies in those communities. And Rosebud Sioux Tribe, they ended up, taking on that tradition and implementing that in their tribal community. So now that's kind of a reoccurring thing. I'm not really too sure how often they do it, but I know in the past they were doing it every month or every other month. And that just gives a cultural advocate the opportunity to come in and teach the cultural teachings of birthing to their people, and also provide, gifts such as maybe diapers, wipes, similar to a baby shower. But it just gives the tribes the opportunity to implement something very similar, to provide for the moms and the babies and their families, to learn more about their culture and where they come from, and just the whole realm of the babies and them being sacred and things of that nature. So I thought that was really neat to see a lot of the tribes were picking that up and implementing that. Next. The Wo'ohitike Collaborative Program, also known as our sexual assault program, is bringing sexual assault services outside the emergency department. So this program is in collaboration with our Oyate Health Center, and many of you may know Oyate Health Center, formerly known as Susan. It is a tribally owned and operated walk-in primary care clinic that's located in Rapid City, and the facility is managed under the health board. And so we partner with a lot of the clinical staff there, in working with a lot of the nurses. We currently have 7 sexual assault nurses that did receive training and that are able to assist with sexual assault examinations now. We are currently working on policies to follow for whenever we have a victim come in, and then kind of like a chain of command with relaying the evidence over to law enforcement. So this grant was, we were awarded this grant in 2022. And so it was definitely a learning experience, and it's really good to kind of get out of, the grant world and look at more of the clinical portion of one of the grants, and, all the work that it takes on that end. And so we are very thankful because we have a certified nurse midwife up at Oyate Health Center who was trained and did sexual assault exams for almost a decade. And so she was able to kind of take the lead in helping our nurses become more comfortable in training for, and a victim that comes in and needs assistance and needs an exam done. And so we finally have our policies up and ready to go. So we are looking at launching our services in November as well. So we're pretty excited for that. More news to come on that. They do currently have a HESAPA SART team, and that's a sexual assault response team. And that is kind of up off the ground now. So they are currently building around that SART team, working with Pennington County law enforcement, child advocacy, social services, Department of Health and Human Services, and they're kind of creating a team that's going to meet monthly to discuss, the needs of the sexual assault program and moving forward, what are needs in the community, such as healthy relationships training. We also focus on domestic violence and human trafficking. Next. Our Great Plains Tribal Maternal Infant and Early Childhood Home Visiting Program. So helping expecting mothers and parents of young children improve health and well-being for themselves and families. So we were also just awarded another 5-year funding for the McVie program. And the McVie program currently services the Rapid City, Rapid Valley, and we subaward out the Rosebud Sioux Tribe. And McVie, previously we worked with the Sisseton tribe. And so we were very thankful for that opportunity. We really learned a lot about the tribe and their people, and they were really huge fans of the home visiting program and the curriculums that we used. The home visiting program also utilizes the Family Spirit curriculum. And the Family Spirit, again, is the evidence-based home visiting program developed for and with Indigenous communities. It includes modules of healthy infant feeding and growth, content for families with children ages 3 to 5 and support for maternal mental health and addresses substance misuse. And so this is this is actually the main curriculum that this program utilizes. And, a few months back, the program manager for McV had approached me and expressed that she felt, that there was still a need for someone to come in and assist the fathers. And I definitely think that's important because a lot of the times, when we're doing groups or we're doing discussions and we ask them like, what does maternal and child health care mean to you? A lot of the times, the audience says, well, moms and babies. And I think sometimes we forget the factor of the fathers. And previous surveys and some studies that we looked into are showing that a lot of the dads are taking on the mother roles. And we need to be able to have the resources for the dads as well. And, I really like that idea because after Healthy Start took a new direction, we didn't have anyone like a fatherhood coordinator. And so this new idea in this position, specifically focusing on fatherhood, is such a great idea. I wish we had the capacity to have a fatherhood worker in all of our tribal communities, because, a lot of the fathers do feel like they're not important. They feel less, than the mother. And, some of the fathers that we worked with in Healthy Start have been reporting that they were left at the hospital with their babies. After the mothers had them, they would abandon the babies and leave them. And they had no resources. They had no help. They had no parenting, education. They had nothing. And so, I'm really excited that we're able to kind of implement something just specifically related to fatherhood. We have an individual that is trained in Fatherhood is Sacred, and they do partner with one of our local Head Starts called Rural America Initiatives, and they also offer those trainings. So it's really good to see that in the Rapid City area, a lot of these Head Starts are incorporating the fathers, and they're making them feel important because they are important. And, sometimes I feel like that does go unnoticed. So the community-based home visiting programs. So of course, they're looking at improving the health outcomes for the women and children. And the home visiting has proven especially successful in outcomes for teen parents, such as increasing access to prenatal care, educating on parenting attitudes, and guiding parents towards school continuation. I know a lot of our community health workers have encountered home visits with individuals who were high school dropouts. And so, the home visiting program definitely has education and training and things of that nature to assist the parents, in re-enrolling back in school, continuing that education, and the importance of it. You need to finish school for your children. If you don't want to do things for yourself, then you do it for your kids. And that was one of the quotes that we quoted for one of the mothers over in Sisseton. She quoted something of that, similar to those lines, that, I know I don't want to do this for myself, but I need to do it for my children because I need a GED, I need a high school diploma to get a good job, to, financially support my babies. And so I definitely think that is, a good thought process. A lot of us may think like that too, we're parents. Sometimes you don't want to do things for yourself, but you have, little human beings that look up to you, and you got to do it for them. So, and then they're looking at offering parent support groups in the program, and that will also help families facing financial instability or limited healthcare access by providing information and guidance on budgeting, things like insurance, meal planning, relevant local resources through culturally recognized approaches. So definitely a good program. they are looking at launching services very soon as well. So they're actually going through the Family Spirit training in a couple weeks. So we're excited to hear back on that. Next. The rural communities opioid response program, neonatal abstinence syndrome, improving systems of care, family supports, and social determinants of health by addressing morbidity and mortality of substance use, opioid use disorder, and neonatal abstinence syndrome. So our core program is predominantly American Indian Alaska Native community of around 4,435 members, most of whom practice traditional Dakota culture. They are they are located on the Crow Creek Sioux Reservation, home of the Dakota Hunkpati Oyate. And so they have limited prenatal services available from IHS and Horizon Healthcare Clinic. These two facilities only operate from 8 to 5 p.m. on weekdays and do not have a hospital facility. All delivery services and specialized prenatal services such as obstetrics or the gynecology are referred by the IHS clinic unit to hospitals located off the reservation. And typically they are referred out to Chamberlain, Pierre, or Sioux Falls. And so again, the women and families must travel at least 27 miles to the nearest hospital, incurring additional financial, mental, and emotional stress before or during pregnancy. And Crow Creek has a high infant mortality rate of 8.5 per 1,000 compared to rates for non-American Indian Alaska Native babies, which were 5.5 per 1,000 births. There is also a growing need to improve the screening and treatment of infectious diseases and STIs among women and family members in the community. While the community members can receive screening services at the IHS clinic and Horizon Healthcare, they face a stigma attached to positive diagnosis. In addition, the tribal schools do not offer wellness checks or STI-based education. And so there's no prevention efforts there for the youth. If left untreated, STIs can cause severe and varied complications, especially during pregnancy. Prenatal issues include preterm labor and premature delivery. And currently our staff that are located in Crow Creek that work under the program, they are doing a lot of community events and a lot of cultural community events, I could say. So in this picture, they did a Dakota naming ceremony just recently. I believe it was last month. And this is a 3-generation family. And so they kind of offer those types of services to the community. They also do a Dakota support group. They do a book club. And it's just really awesome because they get a lot of good participation. They get a lot of good feedback. And the community loves it. And I think it keeps a lot of the moms that they're targeting, it gives them something to look forward to. So they're not, at home, not doing anything. Like they look forward to, our Corps is having this naming ceremony in a couple weeks, let's prepare for that, or let's get a Dakota name. And, I think that's really good because they are super busy down there. We have other programs that are based in Crow Creek as well. So there's collaboration going on. And the program manager, she is just amazing. She really knows her community well. They're very comfortable. She is working with the dorms. And I know she does go in the dorms and provide education sessions. So that's another good thing that they are offering. And so they're currently they're striving to offer prevention efforts for opioid use disorder, substance use disorder, and neonatal abstinence syndrome, which also includes family planning. And then improving access to SUD, OUD treatment programs with information on coping skills. And then assisting in developing communication support recovery for women and families in the Big Bend, Fort Thompson, and Crow Creek districts. And so those are the 3 districts that they're servicing on the Crow Creek Indian Reservation. Next. And then lastly, we have our Great Plains Injury Prevention Program. Everyone knows it as the car seat program. We provide car seat education, distribution, and installation throughout the Great Plains area. They are currently servicing the 4 states, working with different Great Plains programs to provide this type of assistance in the tribal communities. They also offer child passenger safety technician training, where people in your community can become a certified technician to also offer this type of service. And what's really good about the car seat program and the Healthy Start program is we are able to give car seats to the communities. If requested by tribal, the tribes, tribal leaders, they want the training to come to their community. We have the resources and the partnerships, with other instructors that can teach the child passenger safety class. And so this program has definitely been extremely beneficial. We just recently had one of the classes in Rapid City, and we had representation from Cheyenne, Eagle Butte, Rosebud, and Sisseton. And so it was really good to see. A lot of them were law enforcement. A lot of them were police officers. And a lot of their feedback was they wanted to start assisting their tribes in educating the community members on how to properly install car seats, because a lot of their car accidents were left when they had car accidents, they lost infants. And because the infants either had no car seats or weren't buckled in correctly. And so, it really made us feel good because they really want to change. They really want change on their reservations. They want to help be proactive. And that's really a big thing. And so we were able to provide this service to the tribal communities. And currently, we are working with the Oglala Sioux tribe. There's a guy out under the child care program, and he does disperse numerous car seats a week. And so, it's really good to be able to kind of partner, collaborate with them because, everyone does things different, but it's really good to see how the tribes are doing their car seat education now. And it's also good to see that the tribes are wanting to write for these types of grants for their communities, or ask us to assist, with the grant writing process. And so we are looking at having a child passenger safety technician class in the spring of 2025. So we only have them one training annually, but we're hoping in the future that we can offer a lot more and do it on both sides of the state of South Dakota, so East River and West River, so that way the surrounding reservations are able to attend one or the other. So this program also did partner a lot with our Healthy Start program. And so the community health workers in the past that were in the 7 tribal communities, we were able to provide them with car seats, and they were able to do the education, the distribution, and the installation in their tribal community because they were certified technicians. And so definitely a great program. Looking at partnering with Monument Health as well. Monument Health in Rapid City does now have a policy stating that a mother who just had her baby isn't able to leave the hospital until she has the car seat. And she also has to demonstrate, the proper use of the car seat. The baby's buckled in, or if she had any questions, they do have someone on call there that can also go and help if further help is needed to install like into her car. So I thought that was really neat that Monument Health was offering that as well. So we're looking at hopefully partnering with them in the future once we bring our new program coordinator on board and she's certified. Next. And so we are currently working with the Moms Tour. A lot of you guys may know the Moms Tour. They have been everywhere across the United States, more than just the community baby shower across America. They are coming to Rapid City this Sunday. And so we are very excited that they picked our location to come and have this. The Moms Tour connects new and expectant mothers and communities with high mortality, maternal and morbidity rates to needed resources and services. And so we have been in the planning stages for, it felt like forever, but we're super excited that the event is approaching us. And we're hoping that in the future that they come back, because we've been getting some good feedback from the surrounding tribes about this event. So we're still advertising. So if any of you guys know anyone in the area, please feel free to share or reach out to me, and I can definitely get you guys some flyers. But yeah, so that's the Moms Tour. We're super busy with the planning. Next. And then we have our Great Plains Tribal Epidemiology Center, and that's using our data and public health response to improve health. So GP, also known as GP Tech, has been a national leader in the syphilis epidemic response. And so the Health Board of Directors has declared a public health emergency and asked the HHS Secretary to declare a public health emergency to free up funds and data to help with the response. GP Tech has coordinated 2 deployments of the CDC to the area to provide training and extra resources. These response efforts continue, and the impacts of the current epidemic will be felt for years. And so also our epidemiology center, they have many programs under their department as well. And we really like that whenever we're having community events, they come to the community events and they do the testing. And so you're able to get tested, and they offer an incentive. And I think the last time they offered like gift cards, I don't know, like a Visa gift card or a gift card to like Walmart. But it was really, it was really good to see, because we had a lot of our community members very interested in getting tested, and like they mentioned, syphilis is on the rise, and so we're trying to help combat that and hopefully control that soon. Next. And Preetha, that is all I have. I do have a lot of my program managers on the call as well, just in case there's any questions specifically related to their programs, but I will do my best to try and assist and answer those questions. Thanks, guys. Thank you for having me. I know it was last minute, Preetha, but I feel extremely honored that Great Plains Tribal Leaders Health Board was able to share our work and what we've been doing for the communities.
Thank you so much, Chelsea. This was a wonderful presentation, and thank you for sharing all that Great Plains is doing, and the programs sound amazing. I'm glad you have some of your program managers here on the call too. I did want to note just one comment that came in that just said, yes, thank you for addressing the need to support fathers. So I think that's a great note. Engaging with fathers is a really important part of maternal health promotion and child health promotion in general. So I'll invite anybody to ask any questions in the Q&A section, or if you'd like to come off mute, just raise your hand and I'll be able to assist you with that. And as I mentioned with Tessa's presentation, all of our speaker information will be shared out. So thank you for sharing your email and contact information, Chelsea. I'm not seeing any questions come through. But of course, if you do have any questions, please, I'll volunteer them, but feel free to reach out to our speakers to learn more about their projects and work in this area. I'll go ahead and stop sharing my screen. But thank you all for joining, for staying with us through the whole Institute. Really grateful to have been joined by 4 amazing women who are doing incredible work in this space, all in their different regions and with different adaptations to the work that's needed. So thank you so much for our speakers, for presenting, for taking the time, especially Chelsea, as we were coordinating a bit last minute, but thank you so much for sharing your time with us today. I've learned so much and I'm really grateful, like I said, to be a part of this work and to have a partnerships with you all too. If you have any questions at all related to maternal and child health work at the National Indian Health Board, I invite you all to please reach out to me. My email is praj, R-A-J, @nihb.org. That'll also be shared in a follow-up email. Look out for that email. Like I mentioned, we'll have some of our speaker information as well as a survey that you could take to provide feedback on how this webinar session went. And yeah, just thank you so much for joining, and I hope you enjoy the rest of your day. Thank you.